talk about the anterior abdominal wall. In the last class, we talked about the, in general, introduction of the abdominal regions, and as well as something about the peritoneum and peritoneal cavity. Today, we will talk about the anterior abdominal wall. So, let's start. The anterior abdominal wall. What is it? It is a musculoaponeurotic structure that is confined to the anterior aspect and as well as the lateral aspect of the abdomen. And it is bounded above by the xiphoid process. I am telling the boundary. It is bounded above by the xiphoid process, and right and left costal margin. Below there is anterior part of the iliac crest, fold of the groin, pubic tubercle and pubic crest, as well as the pubic symphysis, and on each side it is separated from the posterior abdominal wall by the mid axillary line. Okay, so let's see the boundary of the anterior abdominal wall. So this is anterior abdominal wall. Look at that. Above it is bounded by the xiphoid process, right costal margin, left costal margin, and below it is formed by the anterior superior iliac spine, inguinal ligament. This is pubic tubercle, pubic crest, and symphysis pubis. This is pubic tubercle and this is symphysis pubis in the midline on each side. Okay, then on the laterally on the each side it is separated from the posterior abdominal wall by the mid axillary line. Okay, you know there are three axillary lines: anterior, mid, and posterior axillary line. So if we draw a line along the middle part of the axilla, this is the mid axillary line. So above, below, and on each side, this is the boundary of the anterior abdominal wall. Okay, now come to the what are the layers in the anterior abdominal wall. Okay, the anterior abdominal wall has 8 layers. We know anterior abdominal wall is firm and elastic. What does the firmness does and what does the elasticity does? The firmness, it protects the abdominal viscera, and the elasticity, it allows the enlargement of the abdominal viscera. Now the 8 layers from superficial to deep, that means from above downwards. The most superficial layer is the skin, then superficial fascia. Actually this skin and superficial fascia, they are attached together, so these two layers are found together. So skin, superficial fascia, then 3 flat muscles: external oblique, internal oblique, and transverse abdominis. 3 flat muscles. Then one fascia, that is fascia transversalis, extra peritoneal tissue, and parietal layer of the peritoneum. Okay, we know the parietal layer of the peritoneum, it covers the internal surface of the abdominopelvic wall. Okay, so this is the most deeper part of the anterior abdominal wall. So these are the 8 layers of the anterior abdominal wall. Now we will discuss the layers in details. At first, come to the skin. The skin of the anterior abdominal wall is thinner and more sensitive than the posterior abdominal wall. So the skin of the posterior abdominal wall will be thicker and less sensitive. Now we have to know some terminology in the skin. That is a Langer's line. What is Langer's lines? It is a cleavage line in the anterior abdominal wall. Cleavage line in the anterior abdominal wall, and this line lies horizontally or transversely. Therefore, the abdominal incision for any operative procedures preferably should be given horizontally. Okay, so that the wound heal with invisible linear scar. So look at that, these are the Langer's line. This horizontal or transverse line is the Langer's line. Okay, so what is the clinical importance? When the surgeon give incision on the abdomen, give incision on the abdomen for any operative purpose, if he gives incision along the Langer's line, the scar after the operation will be invisible or minimum, okay, because of the attachment of the collagen fiber. In the Langer's line, the skin of the abdomen, the collagen fiber is the present horizontally, okay. So if we give incision horizontally, the scar will be very minimum or invisible scar, okay. We know the skin has two layers, epidermis and dermis. Epidermis is lined by the keratinized stratified squamous epithelium, and the dermis is composed of the dense regular tissue, okay. And here the dense regular tissue, the main component is the collagen fiber, okay. And this arrangement of the collagen fiber in the Langer's line lies horizontally, okay. So if we give incision horizontally in the abdomen, anterior abdominal wall, the scar, or it will heal without leaving any scar, or there will be very minimum scar. Now come to the umbilicus, another important landmark or feature in the anterior abdominal. This is the umbilicus. What is it? Umbilicus is a puckered scar. It is a normal physiological puckered scar in the anterior abdominal wall, and it represents the site of attachment of the umbilical cord in the fetus. That means in the fetus the umbilical cord is attached at the umbilicus, with the umbilicus. Now what is the position of the umbilicus? The position of the umbilicus in case of adult, it lies in the intervertebral disc between the lumbar 3 and lumbar 4 vertebra, but in case of the newborn and old age, the umbilicus lies at lower level, because in case of newborn the pelvic region is poorly developed, and in case of the old age the abdominal muscle tones is very diminished. Now what is the importance of the umbilicus? The umbilicus has very importance in the respect of anatomical, embryological and clinical view. Okay, we will learn what is the importance of the umbilicus in the respect of anatomical, embryological and clinical view. Okay, now come to the anatomical significance. What is the anatomical significance of the umbilicus? Okay, the anatomical importance. The level of umbilicus serve as a watershed area for the venous and lymphatic drainage. Okay, the venous blood and lymph flow upward above the level of the umbilicus and downward below the level of umbilicus. Okay, later we will see this, and it indicates the T10 dermatome. That means the area of the umbilicus and the skin around the umbilicus, it is supplied by the thoracic 10 segment of the spinal cord. And the last one is, it is a site for the portocaval anastomosis. Porto means portal vein and caval means superior vena cava or inferior vena cava. So it is a site where there is anastomosis of the blood vessels of the portal system as well as the caval system, that means vena caval system. Now one important clinical correlation. I think all of you have heard the name of the acute appendicitis, that means inflammation of the appendix. The skin around the umbilicus is supplied by the thoracic 10 spinal cord, and as well as the appendix, it is also supplied by the thoracic 10 segment of the spinal cord. So if there is infection or inflammation of the appendix, the pain is at first felt at the level of the umbilicus due to same innervation, due to same segmental innervation. Okay, so the appendicitis patient at first they will feel pain at the level of around the umbilicus. Now come to the embryological significance. We know from the knowledge of embryology, at first there were 4 folds in our embryonic life: 2 lateral fold, 1 head fold, and 1 tail fold. And this umbilicus, this is the meeting point of these 4 folds in the embryonic life. Number 2, in the embryonic life, there is a defect which lies in the linea alba at this umbilical level. It is called umbilical ring, which provides passes to the some important structures. So in the embryonic life, at the level of umbilicus, there is a defect in the linea alba, and through this defect some important structures passes. What are the important structures? Number 1, the midgut loop of the midgut, that passage or herniates into the umbilical cord. Number 2, 2 endodermal tubes. One is allantois, and number 2 is the vitalointestinal tract. They also project into the umbilical cord. And these allantois ultimately develop into the urinary bladder in the later life, and vitalointestinal tract ultimately develop into the midgut. And number 3, through this defect it passes, there is umbilical vessels, 2 umbilical artery and 1 umbilical vein, and the remnant of the umbilical artery, it presents in the adult life as a median umbilical ligament, and the remnant of the umbilical vein persists in the adult life as ligamentum teres. Okay, while we study the liver, we will see these ligaments. Now come to the clinical correlations. Some clinical anomalies develop due to defect of this embryological point of view. What are these? Fecal fistula, urinary fistula, omphalocele, and congenital umbilical hernia. Fistula means connection between 2 hollow viscous. Suppose this is a viscera, it has a lumen, and this is also viscera, it has also a lumen. Okay, if these 2 viscera are connected by each other, okay, this is called fistula. Okay, in short. So it may be, if there is defect in the embryological region, so there may be defect in the fecal fistula, it may result in fecal fistula. That means failure of the vitalointestinal tract. If it fails to obliterate, that results in the fecal fistula in the umbilicus. That means if the failure of the vitalointestinal tract to obliterate, there will be a connection between the umbilicus to the midgut. So through the umbilicus, fecal matter will come. This is called fecal fistula. Urinary fistula, failure of the urachus to obliterate leads to the urinary fistula at the umbilicus. So if the urachus persists, so there will be connection between the urachus and as well as the umbilicus. So the urine come from the urinary bladders into the umbilicus, and urine will pass or come out from the umbilicus. Then come to the omphalocele. Omphalocele, we have seen that midgut loop of the midgut, they herniate through the umbilicus, through the linea alba. If it is failed to return into the abdominal cavity, it results in the omphalocele. Okay, that means the midgut will be herniate or come out through the umbilicus. And congenital umbilical hernia, if the intestinal content they protrudes through the umbilicus, it is called congenital umbilical hernia. Now our next layer is the superficial fascia. What is superficial fascia? The superficial fascia, it it is a major site of fat accumulation, especially in the female, and it leads to obesity. So the superficial fascia, in the superficial fascia the fat accumulates. The superficial fascia, where it is attached, at the level of the joining of the two anterior superior iliac spine, the superficial fascia consists of a single layer, but below this line it consists of two layers. That means in the hip bone there is a two spine, that is the anterior superior iliac spine, and in the right side and the left side. If we join this anterior superior iliac spine of the both side, the area above the line, the superficial fascia has only one layer, single layer, but below the line there is two layer of the superficial fascia. So what are the two layers below this line? One is superficial fatty layer, that is known as Kemper's fascia or fascia of Kemper, and a deep membranous layer that is known as the fascia scarpa or Scarpa's fascia. And the space between the two layers, in this space it contains superficial epigastric artery, circumflex iliac artery, external pudendal vessels, and superficial inguinal lymph nodes. Now come to the Kemper's fascia or superficial fatty layer. This superficial fatty layer of the superficial fascia of the abdomen, it is continuous with the superficial fascia of the adjoining area of the body, but over the penis it is devoid of fat, and in the scrotum it is replaced by the involuntary dartos muscle. That means the fascia, Kemper's fascia, it usually Kemper's fascia